Without further ado, we will start our program with Dr. Choi. Dr. Choi is a member of the melanoma team and specializes in dermatology. She will speak to you about screening in melanoma and associated disorders. Jen.
Thank you. Good morning, everyone. My name is Jennifer Choi. I'm a dermatologist here at Yale. I specialize in skin cancer as well as skin care of patients with cancer. And so today what I'm going to talk to you about are what are the major risk factors for developing melanoma, what do we do to screen for this disease, as well as how to detect it, as well as what can we do to minimize our chances of getting it. Okay, so as an introduction, and you heard from Dr. Schnall, what is a melanoma? So it's a cancer that arises from melanocytes, and these melanocytes are the cells that produce what you call melanin, which is the pigment that's found in the skin, eyes, and hair. Now, these melanocytes are found all over your body, including in your skin and in your eyes, as well as in your inner ear, lining of nerves, your bone, your heart, and oral and genital mucosal membranes. Now, melanoma accounts for only 4% of all skin cancers, but it causes the greatest number of skin cancer-related deaths worldwide. Now, this is a substantial public health problem because it's the 6th most common cancer in the US, and there are approximately 70,000 new cases that were diagnosed last year, and if you include melanoma in situ, which is melanoma in the superficial layers of the skin, it goes up to approximately 110,000 cases. The current lifetime risk of developing melanoma in the US is actually pretty high. So invasive melanoma is one out of every 57 Americans, and if you include melanoma in situ, it's 1 every 33 Americans. Now, the incidence of melanoma is actually rising. The annual number of new cases diagnosed is increasing by 3 to 7%, especially in the fair-skinned population. And it's particularly increasing in the population of Caucasian women aged 45 years and younger. In the US, there was a 15-fold increase over the last 40 years, and this increase is higher than for any other cancer. And it's the most common form of cancer among young adults aged 25 to 29, and it's the second most common cancer in young adults aged 15 to 29. And deaths from melanoma occur at a younger age than for any other form of cancer. Having said this, though, the average age at diagnosis is actually in your late 50s to 60s. So it is actually the older population that are more likely to acquire and die from melanoma. So it's both the young and as well as the old population. In the US, sadly, approximately 1 person dies of metastatic melanoma per hour. Now, the best opportunity for cure, and one of the emphasis of my talk today is that it's early detection, because the prognosis of melanoma depends is so strongly associated with the depth of the melanoma when it's first diagnosed. So if you diagnose it earlier, you have a better chance. So that's part of what the whole screening and detection talk is going to be about. Now, when we look at risk factors, you can divide into 3 major categories. 1 is genetic, 2 is environmental, and 3 is the product of how the genetic component interacts with the environment. So when we look at genetic risk factors, basically individuals with a family history of atypical moles, as well as patients with a family history of melanoma, are at increased risk. And in clinical practice, what that means is if you have a family history, it's 1 member with a first-degree relative with a history of melanoma, or several distant relatives with a history of melanoma. Patients or individuals with lightly pigmented skin, those with a tendency to burn and an inability to tan, as well as those with red hair color and blue-green eyes, so all the fair skin type, they're at more risk of developing more damage from the sun and from harmful ultraviolet rays, and therefore more at increased risk of developing melanoma. And then rarely, patients actually will have a DNA repair defects. This would be like an actual genetic disease where they can't repair the skin damage that you get from ultraviolet rays, and therefore they're at much increased risk of developing skin cancer. Now, having said that the lightly pigmented skin is at risk, melanoma can occur in any ethnicity and any race. So, for example, African Americans and Hispanics, while melanoma occurs much less frequently, actually, when they are diagnosed with melanoma, they actually have a higher mortality rate because by the time it's diagnosed, it's actually usually at a more advanced stage. So we tell everybody that even patients with skin of color, they're also at risk, lower risk, but it can actually occur. Now, the environmental factors are the things that you can control. So genetic, you can't really control much of, but environment, you can. So melanoma has been associated with intense intermittent sun exposure, more so than those with a chronic level of low levels of sun exposure. So they've actually found that people of more affluent socioeconomic status actually can have higher rates of melanoma because these are the people that can go on vacations and go to exotic places and all of a sudden have these short spurts of time where they have more intense sun exposure and their fair skin is not acclimated to the sun. So they are more at risk of developing melanoma. Additionally, sunburns. So just one blistering sunburn in childhood or adolescence more than doubles a child's chances of developing melanoma later in life. So that's why we tell everyone, even from very early on, that avoid sunburn as much as possible. And even if it's not blistering, if you've had over 5 non-blistering sunburns, you're also at risk of developing skin cancer. And then they've also found that people who live further down south, closer to the equatorial latitude, these people also have higher rates of melanoma, and mainly because the sun is more intense there. Now, tanning is also associated. So this is a major problem. It means tanning not only from natural sun, but more and more from artificial sources of light, ultraviolet light, and that includes tanning beds. This is becoming a big problem because it's not only here in the US, but also worldwide, where people are using tanning beds a lot. One, because it makes them feel better. It actually raises the endorphin levels, so people can actually say they're addicted to tanning. 2, people think it just makes them feel better and look healthier. So these are all reasons why people will go tanning, but it's definitely not worth it. And we're actually seeing the major population that does these tanning beds is Caucasian women aged 45 years and younger. And it's starting as early as 12 to 13 years old, where we'll see these young individuals go to tanning beds and even go with their mothers to go tanning. And it's a big, big social problem. They found that individuals who have had a first exposure to indoor tanning before the age of 30 have a 75% increased risk of developing melanoma. So if you know anyone who does it, or you're currently doing it, and especially young folks, please tell them to stop because it's definitely related. The World Health Organization has classified this as a class 1 carcinogen, meaning they've decided that it actually has a causal relationship to the development of skin cancer, namely melanoma, and they've also recently found that it's increased risk of basal cell cancer and squamous cell cancer. So it's the same category as arsenic, and I don't know anyone who would purposely ingest arsenic. And as you heard today, California is the first state to ban tanning in minors under the age of 18, and there are several states that are seeking similar regulations. And all of Brazil, the entire country, has recently actually banned indoor tanning altogether. And this is, again, something that's worldwide. There are tanning booths everywhere. And then finally, there are risk factors associated with how the genetic component interacts with the environment. So patients with an increased number of moles, so even benign appearing moles, especially if they have over 50 or 100, it's been associated with higher risks of melanoma. Additionally, if people have multiple, like dysplastic is what we call them, atypical moles. So they don't have that nice normal round appearance. They have differences in borders and color, and oftentimes when you biopsy these, they come back as dysplastic underneath the microscope. Those are also associated with increased risk of melanoma. And then rarely somebody can be born with a very large congenital mole, and those also are associated with increased risks. People who develop freckles have been found to have a 2 to 3-fold increased risk of skin cancer. And then if you have a personal history of melanoma, you've already had one, you are at increased risk of developing another one. The rates are anywhere from 3 to 10% that in your lifetime you'll develop another one. So what do we do to try to detect these? So screening. So total body skin examinations by a dermatologist is one of the most important things that you can get done. Because what we do during these screenings is we'll look you head to toe all over. So that includes your scalp, your eyes, your mouth, your fingernails, your toenails, in between your toes, anal, mucosal lesions, everywhere we look. And they have found that thinner melanomas are associated with physician detection versus just waiting for a patient to come in for a lesion of concern that they've noticed to be changing. So this can usually be done anywhere from every 3 months to every year, depending on your risk factors, but it is very important to actually have this done on a regular basis. Self-skin examinations are also very important, and we teach all our patients who we've seen to do this at home. So once a month to look over your own skin, especially in areas where you can't look, you get a family member to look for you. And you just look anywhere that you can see and look for suspicious lesions, and we're going to go over what to look for. And this actually has also been found to lead to detection of thinner melanomas. So again, it relies on being the clinician, patients, family members being very observant and being very active in your own care. This is an ad that they have been using in a campaign to promote melanoma awareness. And it says, watch your back. And you can't watch your back for melanoma, but we can, meaning it says here, ask your partner to check monthly for new or changing moles or any skin lesion that looks different from the rest, and make sure your doctor or health provider does the same during regular visits. So to see a dermatologist, but also even your primary care physician can take a look, and if they see anything suspicious, they can then refer you to a dermatologist. So in terms of what to look for, many of you have heard the ABCDEs, and this is something that's easy to remember. And what it stands for is A stands for asymmetry. So oftentimes melanomas will be asymmetrical. If you try to fold the lesion in half, it won't fit perfectly like a nice picture. It'll be asymmetrical. The borders are often irregular. The colors are often vary throughout a single lesion. So a single lesion may not just be one nice even color, but can have some red or black or brown or white within it. Diameter over 6 millimeters. 6 millimeters is the size of a pencil eraser, so oftentimes melanomas can be that size or larger, but sometimes they're smaller too, but that's just a general thing that you can look for. E stands for evolving, meaning if you feel like a skin lesion has been changing in any way, it's just been changing in any way, that might be a flag sign. And then S stands for suspicion, and it's not normally included in the ABCDEs, but oftentimes we say S, meaning if you or a family member just has this gut feeling that this is different or it's changing, then that can also be a sign. We also talk about something called the ugly duckling sign. So especially with people with a lot of moles, oftentimes a lot of their moles can look very similar to each other, but then if you look from a broad stance, one of them will look different. That often can also be a flag. Sometimes people will use this 7-point checklist. You don't have to memorize this, but basically it's just change in size, shape, or color, and oftentimes some kind of difference in symptoms. So whether it's inflammation, bleeding, or crusting, sensory change, maybe it's starting to itch or it hurts, and then again, if the lesion is growing over time. So here are a couple of pictures of melanoma. So you can see here that all of these have very irregular borders. They are, for the most part, asymmetrical. They have different colors within the same lesion. That color can range anywhere from black to dark brown to sort of a reddish brown to light brown, and sometimes big, almost even sort of skin colored. So these are all examples of what we call a superficial spreading type of melanoma, and this is a large majority of the types that we diagnose. Is typically diagnosed between the ages of 30 to 50, and this can occur at any site, but it favors the lower legs of women and the trunks of women and men. Sometimes melanoma can present as what we call nodular, so it looks like a round raised spot, and these tend to come up more quickly, just sort of more rapidly over time. And you can see here's like a dark brown to or dark black to purplish lesion, and these often represent about 15 to 30% of the types of melanoma that we see, and it's most frequently diagnosed in the 6th decade of life, and this can occur at any site, but it likes the head, the neck, and the trunk. Sometimes melanoma can occur on chronically sun-exposed areas, and this is what we call a lentigo maligna type. And oftentimes this likes the scalp and the face, especially the nose and the cheeks. And you can see that oftentimes these look like these large brown patches that actually may have existed for years, and then slowly over time they start to change, and their borders become a little more irregular, their colors start to change a little bit, and 5% of these can actually develop an invasive component. for the most part, large majority is actually stays in the superficial layers of the skin. These represent about 15% of the cases that we see. And this is most often diagnosed in the 7th decade of life, so as people get older. And then finally, melanoma can occur on acral sites, which basically means hands or feet. And this is definitely the minority of cases that we see, but you can see here, this is a purplish patch with some scaling, and anyone can easily mistake this as trauma. Sometimes melanoma can even occur in the nails, and it often looks like a single black or discolored streak. Now, these are usually frequently diagnosed in the 7th decade of life, but again, it can occur at any age. And while this actually occurs in any race or ethnicity, but it represents a disproportionately higher number in patients of skin of color. So African Americans, Asians, Hispanics, because they usually don't get the other types. So when they do get melanoma, it tends to be more of this type. And again, it's actually associated with a higher mortality, mostly because of a delay in diagnosis. So what we do to basically survey for skin cancer, our strategies, so total body skin examinations that we talked about, self-skin examinations. Sometimes you'll see us do these free mass screening, free skin cancer screening clinics. Sometimes at like the Pilot Penn tennis tournament, places where it'll attract people who like to be out in the sun. We have specialized skin cancer and pigmented lesion clinics that also have been found to help to diagnose melanomas better and at a thinner depth, and then also better diagnostic tools through advances in technology. So this is just one of the tools that we use. It's called a dermatoscope, and it allows us to see lesions much more clearly, the pigment pattern more clearly, and it allows us to better determine whether something is malignant or benign. There are other things that are being developed out there, including something called confocal microscopy, something called the Melifind, and these are basically tools that when they will take images of your skin and sometimes will allow you to compare it to a whole database of other images and give you an idea, basically an accuracy predictor if this is benign or malignant. But ultimately, in the end, any diagnosis of melanoma is made by actually taking off the lesion and sending it to be read by a dermatopathologist. So far, there's no machine out there that basically you can just put it on your skin and say this is a melanoma or this is not. And so it really does depend on your dermatologist, on the clinician, being able to decide what it looks good, what looks bad, and then all these tools are designed to help the dermatologist. And then just one note in terms of screening, people with numerous atypical moles, they actually do have a higher risk of developing the ocular type of melanoma, the one that occurs behind the eyes. And so we do recommend for those patients in particular an annual assessment by an ophthalmologist. So then what can we do to minimize our chances of getting melanoma? So one of the most important things is to use a sunscreen. So again, because it's the environmental factors that we can change, and genetic we can't change very much. But if you use a daily sunscreen that's labeled as broad spectrum, that will cover both UVA and UVB rays. These are the two different rays that compose UV radiation from the sun. UVB rays tend to be shorter and they're associated with more sunburns. UVA rays are longer and they're associated with more tanning. But both of them have been implicated in causing melanoma. So you need a sunscreen that covers both. And the sunscreen should be at least SPF 30. So what SPF means, it stands for sun protection factor, and this is actually a number that's determined experimentally, but essentially it means the amount of protection you're getting from UVB rays. And it's important to note that SPF actually does not indicate the amount of UVA protection you're getting, it's just UVB. But 15 will screen out the 93% of the UVB rays, SPF 30 will screen out 97, and SPF 50 will screen out 98%. So you'll see that if you go beyond that, it's actually very, very little minimal amount. So SPF 70 will give you probably 98.5%. So really anything beyond 50 is not necessary. And people give me the question, if I put on 15 in my makeup and I'm putting on 30 in as a sunscreen, am I getting 45? You're not. Actually, you're getting just the highest number that you're applying on. So that would be, in that case, you're still getting SPF 30. But anything 30 to 50 is adequate and is what you need. And again, broad spectrum UVA and UVB rays. Now, so in terms of UVA, in the past, a lot of the sunscreens only contained UVB protecting ingredients. Now they usually, almost all of them do actually contain now both UVA and UVB components. And the UVA specifically can be a chemical blocker, and these are basically ones that have to be absorbed in the skin, usually takes about 15 to 30 minutes, and then it will help to block out the UVA rays. Physical blockers work immediately. They're not absorbed into the skin, but they actually work to, it's almost like a sunblock where it'll help deflect the UVA rays. And these are titanium dioxide and zinc oxide as ingredients that you can look for. And oftentimes in children and in patients with sensitive skin, you want to go for one that has a physical blocker. Now, a lot of people don't apply sunscreens on accurately, so the other thing to remember is to put it on in the right way. So you want to use at least a full shot glass full, and that's 1 fluid ounce of sunscreen to cover all your sun-exposed areas of the body and the face. For the face alone, you want to use at least a nickel-sized amount. If you're using a spray, you want to make sure there's an even sheen. You can't just mist yourself and expect to be getting the SPF that's listed on there. And you also want to reapply every 2 hours because it does wear off. So you can't just apply it in the morning and then expect it to last all day. You have to reapply every 2 hours. And if you're getting wet from swimming or sweating a lot, reapply more often. And then don't forget not just your face, but also your ears, behind your neck, because these are very common areas of getting sunburn, and these are also common areas of skin cancer. And also remember that you want to apply sunscreen on year long, because UVB rays are most intense during the summer, but actually UVA rays are emitted in equal intensity throughout the entire year. And also people can get sunburn on a cloudy day because up to 80% of the UV rays can actually penetrate clouds. So just be sure to make sure you're doing it year round. Other things, so between 10 a.m. and 4 p.m., seek shade. Basically try to stay out of direct sun if possible. Stay indoors or actually stay under an umbrella. Wear lightweight long sleeve shirts and pants whenever possible because clothes are better than no clothes. And there are numerous clothing lines out there now that actually have SPF built into them. If you just Google SPF clothing, you'll come up with a whole bunch of websites. And remember that clothes alone, especially if they're wet, will only give you an SPF protection of equivalent to 4. So it's really not that much, and people can get burned through clothes, and people can get skin cancer, but clothes is better than no clothes. And then wear wide-brimmed hat and sunglasses, because this is very important too, because again, it helps protect your face, your ears, and your neck, and then it also protects your eyes. As a dermatologist, I practice what I preach. These are my own 2 kids, and basically when we go to the beach, I have a big, huge sun tent that has SPF 50 built into it. These swimsuits have SPF built into them, and their hats have SPF built into them. And I put sunscreen on them every 2 hours, so they're going to be very well protected. And then basically, a question that comes up frequently is the vitamin D question. So yes, vitamin D deficiency and insufficiency is something that we're seeing more often, but sunscreen use may decrease your skin's production of it because the vitamin D is produced from sun and it's then changed in your skin and it produces vitamin D, but it does not actually lead to vitamin D deficiency. And the vitamin D benefits of sun cannot be separated from the harmful effects, which, like we talked about, are skin cancer, but also can lead to cataracts, immune system suppression, and also premature aging of your skin. So the American Academy of Dermatology, their stance on vitamin D is that the safest way to obtain it is through your diet and through supplements. Because as long as you can absorb these well, basically you'll get what you need through food and supplements. And this is the sun, which I crossed out. And this is my, basically I'm just going to end on this where we see this image and it's an asymmetrical lesion. You see irregular borders, you see irregular pigment and different colors. This looks very concerning for melanoma, but in fact this is actually just a benign seborrheic keratosis, which is an age spot, or what we like to call a maturity spot. So basically, self-skin examinations are important, and to look for suspicious lesions are important, but in the end, if you have any question, just go to your dermatologist, because they're the ones who can tell you right off the bat if something looks good or bad, or they can take it off and help you to determine whether or not it's good or bad. So in terms of your skin, there's no such thing as a stupid question ever. You should just have it checked out. And I want to thank you for your time, and I'm happy to take questions.